Welcome back, everybody, to applications of telemedicine in the optometric practice post-COVID. I'm joined here with my good friend, Dr. Adam Ramsey, and I'm really excited about this talk. Dr. Ramsey, you've got a lot of experience using telemedicine and bringing it into your practice. Looks like we've got a star-studded lineup here. Dr. Marianne Murphy practices at Front Range Eye Associates out of Colorado. Very accomplished career both in practice and in industry, does a lot of lecturing, software development, and really everything in between. And Dr. Adam Ramsey, friend and colleague, of course, a lot of accomplishments so far in your career as well. Practice owner at Socialite Vision down in Florida, very involved in industry as well, co-founder of Black Eye Care Perspective. Thanks both of you for joining me. And we're gonna get ready to jump into telemedicine. But before we jump in, I've got a bonus code for those watching with us. The bonus code is CSME. Write that down, enter it into your raffle card for an additional entry into our raffles. And as I was saying before, please ask any questions you have in the chat. I'll be keeping an eye on that. We'll be fielding the questions. But you guys ready to dive in?
Let's go.
All right. So, as the pandemic started to really spread, what were some of your initial concerns and steps that both you guys took to ensure your practices might be able to survive, and could you continue caring for patients? And I think maybe that will lead into some of the talk around telemedicine and whether you guys were considering that pre-COVID and in what capacity and how that has evolved over time. So,
ladies first.
Thanks, Adam. I appreciate it. Thanks again for having us. This is a topic that obviously Dr. Ramsey and I are extremely passionate about, happy to talk about it and happy to talk to our peers about it. I think the reason we make time for webinars like this is we're so passionate about it and really think that it is an opportunity to elevate our profession and to offer, a set of services that our patients really want and our patients really need. So, pre-COVID, probably like most of you, we had what we called telemedicine, which was, answering phone calls from patients, communicating with them over the phone, through the patient portal, occasionally some patients via text, whatever it was. But when COVID hit, it was an opportunity to step up the game, right? To do it better and to do it right by our patient. There wasn't an opportunity to bring as many patients into the office unless we had to for emergency reasons, but it was an opportunity to connect with them personally, face to face. So we've talked in the past about choosing a platform to do it and then just taking the steps to get it done. So we jumped right in. We've found success using the DoxyMe platform and fine-tuning the email that we send out to patients to introduce them to telemedicine. And it's not ideal for a comprehensive annual exam, but it works really well for us to dive into, a hordeolum or a red eye or an initial eye injury, or differentiating something like a recurrent corneal erosion from something that's a true acute eye infection like an iritis. The interesting thing for patients was if we could communicate with them over telemedicine and have this two-way conversation, if I determined at that point that I needed to see them in office, they were actually more comfortable coming into the office, knowing that we had procedures in place where we were going to be able to keep them safe, but also that their situation was significant enough that it warranted them truly coming in. So it's been successful for us, and it just keeps getting better and better. And Adam, I know you've had some similar experiences to that.
Yeah. When everything got shut down, we considered, and we had been considering telemedicine before. It was just the implementation. And we all go to conferences and we leave out of there with this 12,000 ideas that you want to do. And the hard thing for me is the implementation. So I was frustrated with the coronavirus and everything getting shut down, but it was almost a godsend because it allowed me a moment to sit down and say, if I was going to redo my office, if I was going to redo my flow, what would I do? How would I implement it? And now I had the opportunity and the time to do that. And that is the biggest key with any of this stuff is implementation. Are you going to be on board? Is the staff going to be on board? So now we got to rethink how we deliver care, because for the 5 years before that, we're trying to deliver care by getting you to come into my office. My whole mindset was, how can I get the phone to ring for you to drive to my office? That was my mindset. And now I said, okay, how can I change that in which I can still access and connect with the patient, and they still get that sense of connection and belonging and understanding that Dr. Ramsey knows me and Dr. Ramsey can understand what I need, and I deliver that care to this patient. But how can I do that virtually? How can I make that connection with a phone, with a computer, with a tablet, with a ring light? How can I do that? And that's what telemedicine allowed us to do, is rethink how we deliver care, because we can't sit down and think that we're going to go back to the way it was. Let's just be honest. It is not going back to the way it was. It is not. We can sit there and pout, and we can sit there and kick and scream, but I am so sorry. But it is not. If you do this for 2 years, if this can happen today, the next time anything comes over here, we're getting shut down again. So it's not a matter of what am I doing in the interim. It is, how am I making sure that my office can survive no matter what happens outside the office? How can I make sure that I can pay and take care of my staff and my responsibilities as a business owner no matter what happens outside? And that's the mindset I went into it with telemedicine, because you cannot tell a patient that I can write you a prescription for Maxitrol or Tobradex or Xylet over the phone by looking at your eye in March and April, but in June and July, you have to come in.
Mm-hmm.
I say, well, you gave my husband Maxitrol, it fixed him, really good. So all I'm looking for is the same thing. We got the same little thing. Remember, like I showed you with my eye, and we did the thing with the phone, and I was in my pajamas, and you gave me a script, and it went away in 3 days. You were the best. You know what? I am not trying to come into your office. I'm not. I'm still in my pajamas. I still have on my fuzzy slippers. How can you do that again? So the implementation is not a part-time implementation. Anybody watching needs to understand is, think of it for the long term. Think of it how you can implement it to where it is not a part of your flow, but it just goes into your flow. And I think as we keep going on in the discussion, that is going to be the critical part of the conversation.
Yeah, I think you brought up so many great points there, and I want to dive deeper into all of them. And before we do dive deeper into a lot of those points, implementation, making it part of your flow from now and into the future, just curious, why do you guys think that so many people, or maybe not so many, but a lot of people were apprehensive or skeptical about telemedicine before this all started? What are some reasons you think that they might have been hesitant to consider this as a good avenue?
Adam, you take the lead on that one. I'll
All
follow
right.
you.
I always like to be, the gentleman. I don't like say like women, to get the comments. I'm not doing that today. I think at first when this all started, we assumed that we were going to be stopped for a week or two. So if you thought for a week or two, do I want to do the work of implementing this? Maybe not. Right. So it just depends on the gravity of the situation. I don't think we all had the information enough to realize that how serious of a situation was going to be. And also, optometrists don't like change. We do not we like what we like. We don't like to change nothing. If you try to change one thing in the way they do a refraction, it is messing up their day. So to think that you're going to find a way to really rework and revamp your whole office is not going to work. And then also, we like to discuss why something can't work instead of sitting down and coming up with strategies for it to work. For somebody to say, well, I can't check the eye pressure, so I can't do this and I can't do that. Well, I understand it's not ideal, right? But if what could we do if we had to do it that way? If we were shut down and people still delivered care, because you know what? No matter what's going on with coronavirus, somebody having a sty or somebody having pingueculitis or somebody having bacterial conjunctivitis is still a viable problem. And we need to be the deliverers of care to do that. Now, if you want to go out into your office and do that, you can. But you know what? Some of those patients could and should be treated remotely, because the way I see it is that they were saying between 1% to 10% of patients with the coronavirus were showing up with an iritis or showing up with an eye infection. But that was one of the signs. So do I want to put myself out there? No. I do not. I want to find as many ways that I can do that care remotely. And then if it cannot be done remotely, the way I look at it is I've already done my chief complaint. I know what I'm walking in there to do. So I've already done my chief complaint. I've done my case history. I've done everything. I've pretty much figured out what I want to just cross off the list. I come in, peek, done. I'm out in a minute and a half of that room because I don't have to ask the patient any questions. Sit down, fluorescein, flip the lid, I'm out. Which is what I did when I was shut down. Half the patients I had to come in and see. The other half, they were fine. The ones I had to come in and see, it didn't really take me that long. I think people just don't like change, and that's a problem for everybody.
I think on top of that, it was the way that telemedicine was conducted before in terms of how we billed for it too, right? I mean, in a lot of cases, it just wasn't profitable for us. I mean, you know, to do a 20-minute call with somebody and get paid $18 just wasn't worth my time. There's lots of providers in the past who've said, well, I don't want to have weekend hours. I don't want to have evening hours. I don't want my patients to purchase their materials outside of my office. But guess what? Consumers demanded it. And consumers are going to drive that market. And we can continue to be a part of it, or we can be left behind. So that's part of why, again, we do these things to encourage our peers just to take the dive and jump in. Practice it with your staff. That's the first thing I did. The first person I called on my telemedicine platform was one of my associates. I'm like, let's see how this is going to work. I didn't just dive in with a patient. And then I sent it to my dad, and then I sent it to my mom, and then I sent it to, I mean, you send it to your friends and you play with it, and then you jump right into it. And there's something really reassuring about communicating with the patient this way that gives them a lot of comfort. They really see it as a concierge service. And it's kind of interesting when you think about it, again, in terms of profitability. If I'm billing a 99212 or a 99213 over video versus bringing them into the office, turning the lights on, bringing a staff member in, the cost of goods that I have is much better via telemedicine than it is when I bring somebody in the office. And the patient feels oftentimes better cared for. You know, they look at studies of seniors even, and I was surprised. I anticipated a lot of my telemedicine was going to be with my 30 and 40-year-olds who were, you know, kind of working from home and already on the computer and just wanted to jump over. And it was my patients who were 77 who said, Doc, can't you just turn on your phone and call me on your phone and look at my eye? You know, patients these days are very technologically savvy. It's pretty amazing. And when, you know, the AARP magazine is pushing out 10 ways to have successful telemedicine visits with your doctor repeatedly throughout COVID, if we're the people that are sitting here dragging our feet, you know, who's really the geezer? It's not, it's us. You know, we're being reluctant to change. And it's our seniors that are really proactive. It's our patients who have this expectation that if they can get on and play a video game online, why can't they at least talk to their doctor? You know, and so it comes to, when we talk about applications for telemedicine, while it's acute care, no doubt, like Dr. Ramsey said, there's an opportunity though to do dry eye follow-ups. It's an opportunity for us to hone our skills differently. I know when Adam and I have talked about this in the past, one of the things that you realize a skill that you need to brush up on is your listening, right? Because now I don't have a slit lamp. Now I don't have all my fancy cameras, OCT, Claris, Optometric, whatever it is. I've got my ears, you know, and I've got my eyes where I can have just a perfunctory view of the outside of the eye, but I really got to use my ears. And so it gives us an opportunity to use a different skill set, and it's good to get back to it. And then the last piece obviously is the opportunity, especially for established patients. We have these books of history on these patients. We've got charts for having seen them for, you know, 10 or 15 years. So yes, are there odds that something new can show up in this environment? Of course. But if I have a history like that, the likelihood is whatever they're going to have going on is oftentimes a recurrence of something they've had in the past. And if I was a good note taker in the past, then I'm going to be set up to provide care for them successsually.
Yeah, those were all fantastic points.
I want to say one more thing on that topic.
Uh-huh.
When I sat out here and I thought about this, the day I decided to get serious about telemedicine, I had these systems already loaded in my computer from before coronavirus. A year ago from a conference, I came back, I had it loaded, but I did not really jump into it to the same fervor. And I was sitting there, it was about a week and a half after we got shut down, and I had submitted all my PPP applications and I did all my EID. I did everything I could do. And then I get a text message from a patient, that's a friend of mine, and he says, hey, I did a telemedicine thing with somebody 3 days ago, but my eye isn't getting better. Can you help me? Right. And I sitting down there and I said, I texted him back and he said, I asked him, I said, how? Like, what did you do telemedicine? He said, well, I called my insurance company and that was an option. The insurance company directed me to a telemedicine person and it was a nurse practitioner. She wrote me tobramycin or Polytrim. And I tried it for 3 days and it did not work. And they said, well, can you help me? And then I thought to myself, and at this time, they had already sent me their eye. They sent me the chief complaint. They sent me everything. So I could see the issue from the image. And now I'm about to call in something for free that other person got paid to do. And it was that moment I said, I am not going to let my patient that has been my patient for over 7 years now, has been my patient, get lost to somebody else and then get the wrong care, and they're spending money that they should not spend when they could have came to me first. And I asked him why he didn't do that. And he said, well, you never told me you provided it and I didn't want to bother you. So if I figured they were offering it, I didn't want to bother you. It was the weekend. I know you were shut down because I got the email that you guys were, shut down until further notice, blah, 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 blah. And I said, you know what? I got to figure this out because I'm not going to let somebody else deliver the wrong care to my patient. And then I got to pick up the pieces of fixing somebody else's mistakes because I wasn't delivering it. So I said, you know what? The next day, I went looking at everything. I said, how can I get this to work? And within 2 days, I had an email going out. We're offering telemedicine, and like Marianne was saying, my first patient was like 75 years old, husband and wife that are snowbirds going back and forth. And I'm checking his eye. And she's like, well, I'm going to call you back in 20 minutes because I want you to check my eye too. And at that point, I was just charging, I think I charged $75 for a visit. I wasn't even paying insurance. I was like, $75, pay me, you figure the insurance part out. And they paid me, So don't let somebody else take your patients, pretty much.
Yeah, those are fantastic points, and a lot of what you said, I think we should take a deeper dive into. There's some questions that are popping in as well. So both of you had started talking about implementation, and for those that are watching and want to bring this to their practice, just from square one, have no idea what to do, what are the steps they need to take in order to do that? And a question that came in specifically was, and maybe you guys could provide some insight, are you using DoxyMe or iCare Live? So any thoughts on those two platforms? And then once again, what are the nuts and bolts to really bring this to your practice? How do you do that? And then we can definitely get into a little bit more into the billing and coding because there's a question that popped in here, but let's start with the implementation first.
All right.
Sure. I think one of the things that both Adam and I have agreed on is that we both use the DoxyMe platform. Simple and easy for the patient, easy for the provider just to get started. I think they're still offering at some level, there's like a free starter platform that you can use. So if you can do it, if there's no cost barrier, it's an easy way just to start. Again, with some of the CMS waivers, there's opportunities to use platforms like FaceTime and Skype. Again, we've talked about this on webinars before. My philosophy has been, why start with something that I'm going to have to change later, right? So if I use FaceTime and I do that for a couple of weeks and all of a sudden CMS takes that waiver away and I have to go to something that's HIPAA compliant, now I got to relearn something, and that's just no good for anyone. It goes back to that whole change thing. So I started with a platform like Adam did that was HIPAA compliant, super easy for my patients, super easy for me, and just went with it. There are some elevations to a platform like iCare Live. Obviously, it's designed specifically for eye care. There are opportunities for imaging with iCare Live. There's opportunities for visual acuity checking. There's payment platform options with iCare Live. And I think as simple as it is, I just started with DoxyMe and I've kind of stuck with it because it works, right? It's kind of like an EHR. Once you go into an EHR, unless something goes drastically wrong, you're probably not going to change because it's a big process for the office. Our emails are, customized and personalized for DoxyMe. They point to our customized link. It walks them through the process step by step for the patient. So obviously what that means is one of you in the office has to sit down and go through it like a patient and sit next to you and you're typing a document that says, first, turn on your computer. Second, go to this web link. Third, in the upper right-hand corner, click on this little picture. You're going to be put into a virtual waiting room. I mean, it does have to be done step by step. so that patients can follow along. And frankly, the likelihood of me changing at this point is probably pretty slim, because I'd have to recreate that whole process. And I've had great success with Doxy.me, and I know that Adam has too. So that being said, I'll let Adam speak to, some of the things that happen the more telemedicine you do, and the fact that currently you run into glitches with any kind of technology. So I'll let you speak to some of your experiences with that and kind of how you chose the platform that you're using.
Yeah. I personally currently am using Doxy.me, so I'm not getting paid by them. I just personally like it myself. It was simple. The hard part that I did not like with personally my own opinion, I did not like with iCare Live previously, is that they had to download an application and there was a lot of steps between me and the patient. And when somebody's in pain and I can't see that well because my eyes are red and they're goopy and whatever, then I don't think the patient is going to have a difficult time getting through those steps. Now, if I was in the office and I had all my staff here, but the only thing was the patient was not here, I am okay with using iCare Live, because my staff could then be connected with the patient, go through how to download the app, go through all the other stuff. But when I was setting this up, I was home. I was not doing all that. That was too much for me to do. But if you tell me, if you have a situation in which you're in the office and you're connecting with your patients all around, and your staff can then help them download the app, your staff can walk them through, your staff is collecting their insurance and doing all those other steps, then I could see a platform like iCare Live that has more of a robust platform to it and has more detail. But sometimes simple is better for me. Simple, write down chief complaint, this is what's going on, right eye, 2 days, blah, blah, blah. Call in the script. I hit charge to the patient pays, and I hang up the phone. When you're trying to implement something, I'm thinking through, how can I do it seamlessly? How can I do it without having to do too much explanation to a patient? That's why we chose this route. I personally would have not, patients don't have my cell phone number unless they personally know me. So FaceTime and all the other stuff, I just don't want, I got to have some separation there and the patient, just for my own personal sanity. So I would not want to go and start with the platform, even if it's currently appropriate, that the HIPAA says is, it's HIPAA compliant and you can do it that way. That isn't really HIPAA compliant outside of this environment. So that's why I went down the road of a Doxy.me. But there are a lot of other companies. I know Solution Reach and a couple other ones have added on ways to do telemedicine. And all it is, and we can go into this, is just live video and audio at the same time. And making sure that the signal that's going back and forth is it isn't rocket science. All right. It's just a matter of, is it safe? Is it secure? And is it simple for the patient to use? And is it simple for me to use? Because at 9 o'clock at night, do I want to drive 20 minutes to my office? Not really. Not really. How about you click on this button? Let me see if I really need to see you. Or you're talking about dry eye. Okay, if you want to go to CVS, get this, and I'll see you in the morning if it's still a problem. Because sometimes the patient is describing something to you that is not the real situation. And I have driven to the office at 9 o'clock at night for somebody to have eyelash in there. And they're just like, oh my God, it hurts so much. I think something got in my eye. It's an eyelash, So I love having that separation between me and the patient, and that ability to screen and figure out, do I need to put on pants or not? Like that's my determining factor when I'm at the house trying to figure out if we're going to the office. And having that connection really does help.
Yeah, both of you had mentioned a few times just around billing and getting paid, of course, and obviously that's an important part of this. And some questions have popped in as well throughout the talk here around billing and coding. So maybe just if you could provide some insight into how to properly bill and code. There's a couple of comments in here around CPT codes versus ENM codes. There's I'm looking here at a G code, G02012. G02010. And so if you could provide a little bit of insight on that, and maybe perhaps also provide insight also related to billing. Are you able to charge patients, I guess, out of pocket for this if you accept their medical insurance? How does that work? And if you have a Medicare patient, how do you bill for them? So a lot of stuff around billing. What do you guys think?
I can go here.
So I'm a stickler on this one. Yeah.
Okay, go ahead. You're
I'm
the
a
number.
stickler.
Go ahead.
I would say I'm I'm a stickler on this one. So, a couple things. The G codes, I think of the G codes as like the good old days, right? That's when you're calling a patient on the phone. Those are kind of virtual check-ins, not as sophisticated, I think, as what we think of when we think of telemedicine right now. Then you've got your E&M codes, and then you have your true telemedicine codes, right? So there's some telemedicine codes that are specific for like using a patient portal. I will use those now more as a follow-up than anything else, because if I have an opportunity to see patient over synchronous audio visual, that's always going to be my preference. I want to be able to touch base with that patient and physically see them and ask questions that go back and forth. So anytime I can bill an E&M code, I will. The key is with the E&M codes, I think you'd be hard pressed to bill anything more than a 99213 for a visit, because even to bill a 99213, you have to be able to check vision. You have to do some sort of, baseline visual field. You have to do some motility stuff, and that stuff arguably could be done over video. With a 99212, you don't have to go to that extreme. But with a 99214, you're talking about checking pressures and things that I don't have the capacity to do right now in this environment. So, but where it gets a little sticky is in the documentation and the charting. So there are specific modifiers that are sometimes necessary to use when billing telemedicine. And there are some great webinars that are out there that are specifically on billing. And I would encourage you guys to listen to some of those. I know I've done some, I think Adam's done some in the past as well, that we spend the whole hour literally talking about the specifics in billing. But where I get to be a stickler on it is in the charting. So there are a couple of EHRs out there that will give you the opportunity to bill them as telemedicine visits, and will kind of auto code them for you, which is pretty awesome. There's some that you can set up as an e-visit, and they basically take you through a series of questions. Was it over the phone, or was it over the portal, or was it over video? And could the patient see you? And did you have patient consent? As a lot of these require patient initiation. So you can't just say, I'm going to start calling all my patients, see if anyone's got red eyes, and start billing telemedicine left and right. You can't do that. It does have to be initiated by the patient. But when you're using an electronic health record, just be very careful, because a lot of the electronic health records now, as you guys know, pre-populate the templates. And while you may be clicking, clear cornea, not a red eye, mild discharge, what automatically comes out of that, the output from the EHR says patient was examined with slit lamp and resulted in clear cornea. Well, you didn't use a slit lamp. So you have to make sure that your electronic health record is set up truly for telemedicine, so that it can say the evaluation was performed over telemedicine. There's ways to record what platform you've used. There's ways to record the amount of time. So you can bill based on time, or you can bill based on testing and HPI and review of systems, the same way that you bill E&Ms in the office. So without getting into a ton of specifics, because I don't think we have the time for that in this webinar, there are plenty of webinars out there designed specifically for eye care, and I know some of them have been done by Covalent and some of them have been done by Zeiss before, that I would encourage people to listen to, where you can spend an hour just on billing alone, and they're not as boring as they sound. I think they're pretty interesting.
I concur with what you're saying, and I would say that if you're going to go down this road and have it be a part of your business, you need to spend the time. If you think an hour is too much, that audit is going to be way too much for you. So you do need to figure out how you're doing it. Now, I would say I've been using the 99 codes. I have not been using any of the G codes just in my office. It was not worth the time, and the way they have it set up was a little bit. It wasn't the way I'm utilizing telemedicine. So there are different ways, and I'm not utilizing telemedicine the way it specifies those other codes are. Now, you do want to look at with the 99 codes, making sure that you're answering the questions appropriately. Because I know in my EHR, it was already pre-populating clear cornea, stroma, endothelium. Now, I did not see endothelium and stroma in this when I have my phone up here. So you have to make sure that you are putting down what you actually saw and not pre-populating things. I did not check the adnexa and the nodes, and I wasn't rubbing their temple. So making sure what is going on in your chart is appropriate to what you saw and what you did. And making sure, did you go over the history? Were you asking the right questions in there to validate and to go for that level of a code? Like she said, the 99213 is the highest that I could see when I did my math that you could even do, and that's with an existing patient. The 99202 with a new patient is the highest that I could find the math that you could be done. So you do need to look into that. They have been being paid, and with some of them like Medicare, you could have waited to submit that up to 6 months. So initially they weren't being paid. So if it was a non-covered service, I could then bill the patient. So initially I was charging the patient because it wasn't being covered by their insurance. So I could say, hey, it's not being covered by insurance, you can do this. But now a lot of the insurance companies are saying it is a covered service, and you just have to put it in the correct way. So now I don't think you could charge a patient for that visit out of pocket besides charging the specialist copay. Now you could still charge a specialist copay. Now, if a patient has a $60 specialist copay, would I do the work of billing them also to maybe get $6? No, because the 99202 is like $70. So if I took 60 from you now, do I want to go through the effort of trying to get a couple dollars later? No. But if they had a free specialist copay or a $10 specialist copay, then maybe you would do that. So everybody has to look into what you're doing with your patients. But it is out there, and I would say you need to watch an actual webinar that is actually all on billing and coding, just to make sure that you're writing it in the chart appropriately and you're billing it with the appropriate modifiers.
Yeah.
And then the last thing you want to do right now is really catch patients off guard, right? So I think in that initial email that you send out, there needs to be something in there that says, while you're checking your acuity, while we're giving you the link, that there is an understanding that by choosing to seek care through this method, you understand that A, your insurance will be billed, and you will be responsible for any fees associated with things that are applied to your deductible. So just like you would before you render services in your office, look at the language that you would use in those. And there's some examples online. I know, again, in the other webinars, we've given some examples of language that you could use, but patients do need to know that it's not free. They're still using your brain, and there's fees to be expected to be paid for these services. That being said, in this environment, I have yet to have one patient who said, oh, well, if this is going to cost me, I'm not going to do it. Nobody's done that. In fact, nobody's even asked me, what is it going to cost me? Right. So what we're trying to figure out is, what is that threshold? What can you charge for those after hours services for patients that are non-covered? What is, what's the push point or the tipping point for those patients where they realize it's no longer convenient if it costs me $150. But if it's 100, I'll do it. But if it's 150, that's my same copay at the ER, and I'll go there. Like, again, we're not seeing that. I think you have after hours services that are tied to the patient demand. But it can be a service that your patients want, need, and can be profitable for the practice.
I have not had a patient tell me they would not pay.
Yes. Yeah, it doesn't happen.
I go on Amazon and I buy stuff on Amazon that I know I can get cheaper if I went into the store. I know I'm overpaying on Amazon. But you know what? It's going to come to me at my house before I would have the minute to go to the store. So if I want it tomorrow, I will buy it on Amazon. No, I'm paying 5-10% more than that actually cost if I took the 20% off coupon and blah, 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 went in there. But I go ahead and pay out of my pocket for convenience. I'm telling you right now, the rule of thumb is, how much can you charge if I don't have to put on pants? And patients can listen, if I don't have to put on pants, I can get my eye taken care of, and I think I pay $100. Whatever, there's a threshold there for the patient, and there's a threshold for me. How much would I charge if I did not have to drive to the office? So there's two levels. You can go up on your pricing to say that it's convenient to the patient, right? Or you could say, if I don't have to drive to the office and turn the lights on and take everything off, what would I want to do? How much would I charge to be the convenience for me? And I think that's what every doctor has to think for themselves while you're doing it. And there's no reason why it has to have one price. There's no reason why it has to have one thing. Depends on the level of complexity of the service. It depends on a lot of things. So let's not look for the easy answer. This webinar is not going to give you the easy answer that you never have to go do any more homework about. No, we're going to have to use our brains and decide that we're gonna think through it, and we're going to make sure that we're making it fair to the patient and fair to the provider as well.
Yeah, but both of you had brought up a couple of interesting things around documentation, and a couple of questions came in, and then obviously, of course, around when is it appropriate to use this for what conditions. So definitely want to to hear your thoughts about what kind of cases or what kind of conditions this type of thing is really well suited for. Before we jump into that, just branching off the previous topic, someone had asked a question here: which EMR programs are telemedicine documentation friendly? So that kind of came up in the conversation a bit before when we were talking about billing coding and documenting, making sure you're not saying you're touching the glands here unless you're actually doing it. So I guess first that question, then let's dive into case examples of when this is actually good and maybe when it's not so good.
Yeah, I'll jump in because I see Adam looking at me.
Yeah.
But very simply for me, when it comes to EHR, I've used Affinity EHR. It's what I had in my practice before. I didn't opt to go to it because it had a telemedicine platform. But one of the advantages for me in being on a cloud-based system is when COVID happened and we all went on shutdown. Being a cloud-based system, it was something that they were able to implement in the practices, and they deployed it very quickly. Interestingly, they did come out with actually telemedicine that's available through the software itself. But like Adam said, it required the patients to download an app. And so while that's actually even built into my software, I didn't go that route because to me, it was going to be more complex for my patients. So Affinity EHR, though, does have opportunities for click boxes that are useful for billing a variety of different telemedicine visits, whether it's the E&M codes, which I agree with Adam, or what I use predominantly, or whether it's billing telephone, patient portal, or G codes. I can document either of those through my EHR. So Adam, I'm not sure what you're using.
My system is not as fancy as hers. She's talking about hers because it's step her through. I'm using Crystal Practice Management, and I have a server system, and I'm literally just logging in from home, doing like a remote in to my desktop. So I have the chart where I can still look at my patient stuff up, and then I will either be using, and we can go into this separately, but I use my phone and some sort of holder to hold the phone with a light, so that I have my computer and I have to be able to see the patient, or I'm doing a split screen on there so that I can see the patient and then pull the chart up. But for the most part, I'm reviewing the chart before I see the patient. Because with Doxy.me, it gives you a text message and email telling you the patient's waiting. And I look the patient up first so I know what I'm walking into, and then I do it. With the separate questions you're asking about what conditions, I think once again, we got to stop trying to put this into individual buckets, okay? The patient's not going to call me and tell me I have a scleritis in my left eye. It is a +3, and I think I need this, and it started this thing. That's not going to happen. The patient's going to call and say, my eye is bothering me. I need your help. That's it, okay? After you get in, if you can see the patient and you can complete the exam to where you feel comfortable with it, then you're done. If you cannot complete the visit and the exam to where you feel you've completely checked to make sure it's not herpetic keratitis, if it's not retinal detachment or whatever, then you tell the patient, I'm sorry, Mrs. Smith, I'm happy that I was able to see you this way, but I don't think I can accurately diagnose what's going on, so I need to see you in the office. So I can be there in 20 minutes. Can you meet me there? That's it. If you feel comfortable, when you look at it and it looks like, oh, I stuck in my contacts, you look at their eye, it's one eye red. This was the eye I stuck in my contacts, and you feel comfortable with the patient's history because you see they sleep in their contacts every year, and you've been renewing their prescription every year, regardless. Then you can do your own judgment. But look at this system as a stopgap, as a way to look at the patient and start your case history and to start your chief complaint. And if from that case history and from that chief complaint and from the medical history, you feel comfortable prescribing, then finish. If not, put on your pants, get to the office.
And I think, some examples of how it can be used are in kind of this in this kind of post-COVID environment where I don't even know if we're post-COVID, whatever. We're not in an active kind of shutdown right now, but for me, it's in post-care, right? So I have a patient who is a glaucoma patient who I really needed to see in the office because I needed to check pressure. I needed to check response to medication. I needed to check a variety of different things. I needed to do a visual field. This patient is immune compromised. I bring the patient in first thing in the morning with just staff before I even get here. I'll come in and check a pressure and the patient will leave. Oftentimes what I'll do then is say, I'm going to follow up with you later over telemedicine. And I have the opportunity to screen share, to show their visual fields, to walk through it where we can sit through very comfortably. They're at home, I'm at home, especially with a new glaucoma diagnosis, or in my case, a patient where I'm changing their therapy. When you're sitting there across from them right now with a mask on and they've got a mask on, if they're hard of hearing or they really want that personal connection with you that they've had over the years, it's actually been really nice after the fact to send them home. Let's get on video. We can be face to face. It's real time. We can laugh, we can joke, and we can talk about what's going on with your eyes. And that's been really handy. But I agree with Adam. We use it really as a triage system in our office. And, if someone comes in and they've got a first time red eye and they're complaining about a bump on their lid, I might start them on something and do exactly the same thing. Say, we're going to follow up with you in 3 days. And if it's not better, or if it gets worse at any point, we're going to bring you in. But if I'm sitting there with that split screen and I'm looking at a patient who's been on Valtrex straight for 15 years and has had recurrent visits of red eye, I'm not going to even chance it. I'm going to say, I'm looking at your history, come in. But the patient feels so much more comfortable knowing that it's probably not something that's just a fluke, and it's probably something that's serious that warrants me going into the office. And so they come in with a level of confidence that they really need to see a doctor, right? So we've used it also sometimes for contact lens follow-ups. If I'm putting someone in a new monovision, I might see them by telemedicine as a follow-up. How's your reading? Do we need to give you a little bit more? Do we need to give you a little less? Do I need to know that it's exactly a plus net 0.75 ad versus a +1? That's handy. I like having that in the future. But in this day and age, if I've got someone who's an RN and she's working in a COVID unit in downtown Denver, do I really need to bring her in here to find that difference of a quarter if she basically tells me when I'm drawing meds I'm still having trouble? I'm smarter than that. I can fix that. I can set a trial for her out at the front desk, or even tape it on the door and she can swing by and pick it up when she gets off at 10 p.m. Those patients are so appreciative, and I think the loyalty that we develop with these patients at this point is something that you can't trade for anything else.
So can we can I give a couple scenarios that I'm using the telemedicine that we haven't discussed so far?
Yes.
All right, so I think we got to think bigger, think outside of the box, right? Remember I told you I'm trying to recreate how I'm doing my office and saying, how can I connect and engage with the patient? And how can I make it as convenient as possible? So about a month ago, I wasn't in the office that day, but the office was open, right? So the staff was in here. I wasn't in the office. Somebody called and say, I'm having flashes and floaters. I'm having this issue. I don't have any insurance. Can you come in and see me? Now the patient is like, I'm outside your office, expecting me to be there, and I'm not there, right? So I call the staff and I say, hey, Claire's, give me an ultra wide field picture on there, and then pull it up and let me see what we got here. Because the patient had no insurance. So yes, I could be mean and just say, well, you got to go there and it's $400 to go to the retina specialist. The patient said, I can't do that. I said, well, you know what? If you come to my office and you do this, this is what it's going to cost. You do this and let me see if I can help them. And I was able to pull it up, and you saw one little floater, and I said, listen, it's okay. I can see you separately, or I can see you tomorrow. We had an ability to utilize the systems in our office to still benefit the patients. And I think when you have the technology, let's figure. And then I was able to set up a telemedicine visit with that patient, and then say, okay, even though I was not in the office, I was able to have my staff do all of the tests that I would have done in the office anyway. And with the huge picture that I saw, there was no tear, there was no detachment. It was just one little floater that I would have had to drive an hour away because I was out somewhere else to come back to see that patient. For them to have this one floater they've always had, but they were just bored that day and they wanted me to come in and take a look. So I think you can really relook at how you're actually doing it. If you have the technology in your office, find ways. The telemedicine, all it is a virtual way to connect with the patient that we always did before. We were using FaceTime before. We were using Skype before. This is not something new. It's just now we're doing that to connect with patients. And then how do you find a hybrid of that? There are times when you're going to be able to utilize the equipment in your office, and like she said, be able to connect and do the follow-ups with the patient to maybe reduce the contact that the patients have with other patients, with other staffers. Could you have the patient come in and do all the testing one day, and one day, like Mondays is all testing on days you may not be in that office, and then you call them out on Tuesday and do all your follow-ups with everybody that was in the office? There are ways you can reimagine your office. The last way I'll give y'all, and this is a little freebie for the people that are watching here live, we have started doing virtual fittings with glasses and mailing people glasses, and then being able to sit down with the patient and say, hey, bring all the glasses you have at home and let me see what styles you normally wear. Because I bet you, if you ask a patient to bring all their glasses when they're at home, they'll pull up 6, 7 pairs of glasses that they usually wear and they interchange. And you can see the style, and you can ask them, read the numbers for me. And they say 52, 17, 140. And you're like, oh, okay, I know your eye size. I kind of get an idea of where you are. I have your prescription. And then we're styling them remotely using a telemedicine platform in which we're getting sales from that. So there are ways, if you sit down and say, let me reimagine using technology, using my brain, and saying, how can I connect with the patient? All telemedicine is a way to virtually connect with the patient. Now, what you do with that virtual connection is only limited by your imagination. It is only limited by the questions you can ask the patient and the response that you can get back from the patient. Because if a patient tells me my scalp is hurting and it hurts right here on this side of my head is hurting, I know 99% certainty what the answer is. That I need to put rose bengal in that eye? Maybe not. Maybe not. I could actually prescribe knowing that that patients don't come in with that complaint. That never happens unless it's that, So there are ways, if we take away the technology, you can connect with them that way. Or having all the technology and I am not there and the provider isn't there, and I can still make that connection to the patient. And I think even in a better instance, because the patient is sit down, they're calm, they didn't just go through an hour of testing, and now you're able to show them and show everything to them, and they're going to tell all their friends, and their friends are going to be like, well, they pulled up those scans for me, and I was able to see it, and I was able to show my mom, and my daughter was with me because she's at home, so my daughter was able to see it and understand what is going on, and you can do that all remote and virtual if you reimagine what telemedicine is and reimagine it for your office.
And I think one of the questions that I get often from my peers is really about the implementation too, right? And when you think about it, it's like, well, how do I schedule them? I have patients running in my office every 25 minutes. So where do I put the telemedicine patients? And I say, start simple. Start simple. Always double book one at the first appointment of the day and double book your first one after lunch. Those are always available in my office because I know when my 8 o'clock patient shows up at the office, it's going to be 15 minutes with a technician before I can see that patient. So guess what? During that 15 minutes, I'm seeing a telemedicine patient and I'm kind of double dipping, if you will, right? I'm making money on 2 patients at the same time. They're coming in and I'm taking care of 2 patients at the same time. And then I'll do the same thing right after lunch. When we're busier than that, because sometimes we'll see 7 or 8 telemedicine patients in throughout the day. At first, I was kind of nervous. I was like, I want to be sitting on the platform waiting for that patient. So as soon as they log in, I'm ready to go. Well, guess what? What I found with my patients is if I'm working them in through the day, they would much rather be sitting at home, having a cup of coffee, watching their favorite TV show, holding their phone, not wearing a mask, than doing the same thing in my office, right? Where they can't grab a coffee, they can't have a beer, they can't, whatever they're doing, they can do at home and they can be waiting there and they don't mind. They still think, I'm the greatest gift because I came to them in their living room while they're sitting with their beer. So I've gotten over the fact that I don't want them to wait, but like in the office, right? I don't like to keep them waiting more than 8 to 10 minutes if I have to, but you can always find a way. And really the same thing that we've done in the office, we typically have techs and scribes. And so if I'm running behind with an in-office patient for whatever reason, like I was getting onto this webinar, I can send a tech onto the telemed, and they can start doing the case history for me, right? They can start reviewing the patient's history. They can start doing all of the same things that I would be doing. And then they report to me just like they would if the patient was in office. So, first patient of the day, first patient after lunch, if you're just getting into it, that's an easy opportunity to double book, but you'll find that there's opportunities to really work them into your regular patient care throughout the day, especially right now while you're seeing patients further spaced apart because you're having to disinfect every exam room between every single patient, right? That takes time. You could be seeing more patients.
Yeah, these are all great points, and I think it's safe to say that telemedicine can definitely be leveraged now and into the future, of course, add into your workflows, offer as an additional service, and enhance what you can offer patients. And we really just have about 1 minute left here, but I wanted to just pose one last question that just came in, and it's around whether or not there are any additional or different legal concerns with doing virtual eye care, virtual optometry. So any insight into that?
My
You can
simple
get
thing would
sued
be
for
check with
anything.
your provider. Yeah,
Yeah.
you gotta take good care of patients. You have to have their best interest in mind. You have to do no harm. You have to be smart, like Adam said. And if you need to go into the office, don't short them on that. Go into the office, but do make sure that your malpractice provider does cover you for telemedicine. I know some of the more common ones we found out do. Our provider had no issues as long as it was allowed in the state. It was allowed by our insurance carrier. I don't know about you, Adam.
Yeah, I agree. I mean, be good to the patient. Patient is not going to sue when you did the right thing and you followed up. That's what we always say. When you write a prescription, follow up with the patient after you put the drops in. If it's not getting any better, the same way you could call them the first time, call them the next time. The next time you're in the office, what I do, if I saw patient telemedicine on a Saturday, Monday morning, 10 a.m., my staff is calling them to say, "Hey, how's it going? Dr. Ramsey's in the office. Do you want to come in?" "No, it's feeling much better, thank you." Or "No, it's not. It's not any better." "Okay, we can see you in 15 minutes." And you know what? The follow up is what messes up almost everybody. You can't prescribe something and don't know the end result, and especially that you didn't see it. So if you follow up, you're good. And as we come off here in a second, my favorite cartoon growing up was the Jetsons. And the more I see this stuff happening, I feel like the Jetsons had it right. And this was 20 years ago, but they would come on the screen and they would zoom around and they would, make food by punching it into something and everything. And I'm like, listen, the Jetsons had it right 20 years ago. And I think I'm going to rewatch some more of those cartoons to figure out what happened 5 more years from now.
While you're taking patient telemedicine calls, right?
Yeah.
There you go. Works both ways, doesn't it? Well,
Does.
thank you both for joining us today. Really appreciate you taking the time. I know we could go on for hours. We'll definitely do a part 2 to this at the next event. So thanks again, and have a good rest of your afternoon.
Thanks, guys. Bye. Use your ring light. Use your lighting. You got to use things to help you out.
Great, guys. Have a great afternoon.
This is not going to work unless you have the items. You got to have the toys to make it work.
Thanks again.
Yeah.